Aortic stenosis is the most common adult valvular heart disease. It is a progressive obstruction of left ventricular outflow caused mainly by degenerative calcification, bicuspid valve, rheumatic disease, or radiation injury. The dominant mechanism is an active fibrocalcific process. Its injury leads to lipid deposition and inflammation, followed by transformation of myofibroblasts into osteoblasts-like cells, causing calcium deposition. Traditional risk factors include hypertension, diabetes, smoking, chronic kidney disease, elevated LDL, and lipoprotein A. Bicuspid aortic valve is strongly associated with ascending aortic aneurysm. Left ventricular outflow obstruction creates a pressure gradient across the aortic valve. The left ventricle initially compensates with hypertrophy, but eventually develops fibrosis and diastolic dysfunction. Severe aortic stenosis is defined by mean gradient greater than 40 millimeters of mercury or valve area, less than 1 square centimeter. Low flow, low gradient disease can make severity assessment challenging. Myocardial oxygen demand increases due to left ventricular hypertrophy. Coronary perfusion is reduced by high left ventricular end diastolic pressure, leading to subendocardial ischemia, even without coronary artery disease. Classic symptoms appear late and include exertional dyspnea, angina, and syncope. Syncope often occurs during exertion due to fixed cardiac output and systemic hypotension. Physical examination reveals a slow rising carotid pulse called pulsus parvus et tardus. A harsh systolic ejection murmur radiates to the carotids and is often accompanied by an S4. Echocardiography is the primary diagnostic tool. It assesses valve area, calcification, and gradients, with severe disease defined by valve area less than 1 square centimeter. Natural history shows progressive narrowing of the valve at about 0.1 square centimeter per year. Once symptoms develop, survival drops dramatically without intervention. Symptomatic severe aortic stenosis has a median survival of 2 years with dyspnea, 3 years with angina or syncope, and less than 2 years with heart failure. Medical therapy does not slow disease progression. Management focuses on symptom relief, avoidance of dehydration, and careful control of hypertension when present. Definitive treatment is valve replacement. Surgical aortic valve replacement is preferred in younger patients, while transcatheter aortic valve implantation is used in high surgical risk cases. Balloon valvuloplasty is mainly used in congenital cases or as a bridge in unstable patients. It is not durable in calcific adult aortic stenosis due to rapid restenosis. Risk stratification and heart team decision-making are essential. Patient age, anatomy, comorbidities, and life expectancy determine the choice of intervention. The key clinical takeaway is that aortic stenosis is a progressive and fatal disease once symptomatic. Timely valve replacement dramatically improves survival and quality of life.